Thanks for the invitation. The goal today is to talk about fertility preservation and the program that we were able to set up here at the University of Miami. Why should we do this? Is it worthwhile? But certainly, Ryan and I have known each other for a while. We've crossed paths a lot, interacted a lot, and I'm very happy for Ryan to have gone back to UBC and setting up the program. Very excited that he started his fellowship. Happy to have Luke here, and certainly interacting with both of you has been wonderful. So we'll start off with a real case. It's a 32-year-old male presenting with his wife. They're trying to achieve pregnancy. At 14 years old, he was diagnosed with Ewing sarcoma and underwent a removal of a pelvic tumor and chemotherapy. A semen analysis basically shows no sperm. 42-year-old male dentist presents with his 35-year-old physician wife desiring a pregnancy. At 16, he had pediatric non-Hodgkin's lymphoma, underwent chemotherapy, radiotherapy, was really not offered sperm banking prior to his treatment, and his semen analysis also shows no sperm. The good news, at least in the US and definitely worldwide, the cancer survival rate is increasing. So patients diagnosed with cancer are getting treated and are living longer. Bad news, however, the incidence of all cancer diagnoses in patients younger than 65 is actually increasing a lot more than older than 65. Why it's happening, that's not the debate today, but we just need to know that it's not a diagnosis of the elderly, it's happening in younger people as well. And unfortunately, 9% of all of the cancer diagnoses in the United States, at least, are in patients younger than 45. And in fact, 1% of all of them are in patients younger than 20. So certainly, cancer was often thought, just like heart disease, as a disease of the elderly, as a disease of aging, but it's certainly happening a lot more in the younger patient population. And therefore, both men and boys are at risk for infertility. If you look at the incidence of cancer in men younger than 20, about 24 boys per 100,000 population are affected. If you just expand that age to 40 to 44, it becomes 148 per 100,000 population. But the good news is that 5-year survival rate in younger patients is close to 85% for men between 0 to 19 and close to 75% between 0 to 44. So they're going to live long, right? 3/4 of the time of the adolescent boys and young men who get diagnosed with cancer are going to be alive at 5 years. Not true in the elderly population, but certainly true in the younger population, that they are going to live. How they're going to live, all the consequences they're going to face, that's what we're here to talk about. In cancer survivorship, fertility preservation, and risk of fertility and starting a family are all part of cancer survivorship. And I think we as urologists need to play an important role in cancer survivorship, especially in men. So what are some of the treatment effects on male infertility? So if you do treat cancer, we presented 2 cases. One patient underwent pelvic tumor removal, and the other underwent chemotherapy, radiotherapy. All of this surgery, chemotherapy, and radiation, all of them can cause several side effects leading to male infertility. The most severe, of course, which we saw in both those cases, is Azoospermia, where there's absolutely no sperm in the ejaculate. It can cause oligospermia, meaning lesser sperm count. It can cause poor quality sperm, meaning there is sperm, but it has undergone DNA damage. It has mutations. It's not functioning well because of longer lasting effects of chemotherapy. It can lead to sexual dysfunction, leading to anejaculation and or hypogonadism, which is testosterone deficiency because of either radiotherapy or chemotherapy affecting the Leydig cells inside the testis. So let's talk a little bit of biology just so we understand why chemotherapy and radiotherapy cause infertility. Spermatogenesis, as we're familiar, has several stages, and the whole process takes about 72 days. But the most important thing to understand is that both radiotherapy and chemotherapy target the fastest dividing cells in the human body. If you really think about fastest dividing cell in the human body is actually the germ cell that makes sperm. And so these are the cells that get actually targeted first, even before the cancer or the tumor cells. And so it's important to understand that if you truly lose germ cells and don't have any more cells to divide, that's what leads to azoospermia and sometimes prolonged azoospermia. So cancer can actually have a multi-factorial impact on spermatogenesis. So it's not just it affects spermatogenesis, but the whole cancer itself can lead to a systemic illness that affects the hypothalamic pituitary gonadal axis, especially CNS tumors that can have a direct impact on the hypothalamus and the pituitary gland, both of which are extremely critical to make gonadotropins like LH and FSH that are important for both testosterone production from the testes as well as spermatogenesis from the testis. So it can either be an impact on the hypothalamic pituitary gonadal axis or a direct impact on gonadal function because of the systemic illness that cancer does generate. So we'll talk a little bit about the mechanism of action of the different anti-cancer agents, and we won't belabor too much on this because this is truly oncology. But the point that I want everybody to understand here is that alkylating agents, and we'll go into a little bit of what alkylating agents are, and DNA strand breakage these two are probably the worst in terms of radiation and the type of chemotherapy that can lead to long-lasting damage. So if you look at what are some of the chemotherapy agents that are lower risk, meaning they can have temporary oligospermia or temporary azoospermia, but most people will recover, are vincristine, methotrexate, vinblastine, mitoxantrone. And some of the toxicity that's been documented, about 1 month of azoospermia in 38%, and oligospermia in majority of them, and about 4 months have normozoospermia in 63%. So it's important to understand that even though we call these low-risk cancer treatments, there's really no risk chemotherapy. Chemotherapy will cause some risk, and this whole concept of when you speak to oncologists, they're like, oh, I'm giving a fertility-friendly regimen. I don't think we should be thinking about banking sperm. I think this guy's going to do okay. I don't think we need to get there at all. And these conversations are difficult conversations to have because this is what has been taught traditionally, but it's just important to understand that there is really no risk chemotherapy, and patients should be aware of a potential risk. What is high risk? And this is important for us to understand because this is often used, this is the regimen we use in testis cancer, and as urologists, we are also partly to blame where we don't think about fertility preservation in our own patients. And all the alkylating agents, so cisplatin, carboplatin, doxorubicin, BEP, which is a regimen used in chemotherapy, ABVD, a regimen used in lymphoma, all can lead to azoospermia, and in 10% of patients, prolonged azoospermia. So for example, cisplatin has been shown to have about 1/3 of the patients become azoospermic 20 years post-treatment. So this whole concept of like, oh, don't worry, your sperm will recover, just give it some time, not true, right? There's a 1/3 chance you're never going to have sperm after you receive cisplatin chemotherapy. And if you look at ABVD, same thing with 40% azoospermia, and BEP regimen, 30% decline in counts with recovery in about 80% of patients within 5 to 8 years. The message there is that you're never going to go back to baseline. There is a certain risk that you will lose a little bit of sperm, and there's a pretty significant risk if you do get these alkylating agents and cisplatin and radiation to actually become azoospermic for a lot longer. Certainly the highest risk is with cyclophosphamide and busulfan and ifosfamide. There's about an 80% chance probability of azoospermia leading to germ cell failure with many of these agents. So I think that's what the message here is, that yes, there is low risk, there's medium risk and high risk chemotherapy leading to impaired sperm count, but really all of them carry some amount of risk, and the patient should be aware if they're thinking about having in the future that there could be a potential for losing fertility permanently.
Ranjith, is there a difference between pre and post-pubertal males?
We should get there. Yes, absolutely. I think if these agents are given pre-pubertal, I think they have a much higher risk than post-pubertal, because you truly never gave a chance for some of the germ cells to escape spermatogenesis and actually make sperm. In pre-pubertal, there is absolutely no spermatogenesis, and so if you destroy the germ cells at that time, the risk of having infertility is much higher in the prepubertal age? It's a good question. Yeah. Radiation can also impact spermatogenesis. Despite shielding, even scatter radiation less than 1 gray can result in gonadotoxicity. So if you get 3 gray or higher, much lower doses compared to what we treat for prostate cancer, you could have permanent azoospermia. And even radiation can affect Leydig cells, leading to hypogonadism. If it's more than 20 gray in prepubertal times or more than 30 gray in postpubertal, can still lead to hypogonadism. And fractionated protocols, so we're not giving the dose at the same time, we're giving it over time. All of them can have similar outcomes. So this whole concept of like, oh yeah, I'm putting a shield, I don't think there's much radiation, I don't think we should worry about spermatogenesis, incorrect. They can still lead to impaired spermatogenesis. So a very nice study by Eric Chow that was published in 2016, where they compared survivors of cancer survivors versus their matched siblings. So the red curve shows the survivors, and the matched siblings shows the blue curve. And if you see both pregnancy and live birth, very nice demonstration showing that if you look at the number at risk, certainly the live birth rate and the pregnancy rate in cancer survivors is lower compared to their siblings. And so important to understand that they are going to have risks in the future, regardless of how they get treated. If you truly look at modest risk of birth defects in post-treatment fathers, or what's going to happen to the sperm after you receive treatment, is it going to have genetic damage? Is it going to have mutations? Are the kids going to be born with birth defects? Yes, there is a small risk and it's higher, but it's pretty modest. And I think encouraging cancer survivors to go on to get families without worrying about the risk of what treatment they had is important. But certainly, if there was banked sperm pre-chemotherapy, pre-radiation, I think we should encourage them to use it if they have those means. So what happens in this discussion with an oncologist and a patient? As soon as you hear the word cancer, everything stops. They really don't listen beyond that word cancer. And I think this has been elucidated in many studies. It's not just fertility and cancer survivorship conversations. It's really all of the social support conversations that doctors try to have during that visit when the diagnosis has been given, that it becomes a very big challenge that it's really not had at that visit. So if you do ask a nice survey done, oncologists, why don't you freeze sperm? You know, it seems so straightforward. It's fairly inexpensive. Most of the time, reasons are there's just too many acute health issues we need to worry about starting chemotherapy today. We need to make sure the cancer does not metastasize. And then if you ask a little bit more, they say, oh, sperm parameters in kids are not worth freezing. There's so little. I don't think this is enough. They should just wait till they become adults. And this is obviously a famous line used. I'm treating the patient with a fertility-friendly protocol, fertility-friendly chemotherapy agents. And so I think we're okay. And if you ask parents, survival is important, right? We need to worry about whether my kid or the young adult is going to live 5 years or not. You know, we're not thinking about them starting a family. We just need to make sure they're alive. I need the chemotherapy to be started tonight on Friday. And so all of these are reasons that are used for why we should not be freezing sperm. Very nice survey done out of MD Anderson in 2002, 900 males with cancer between the ages of 14 to 40. They asked whether they were informed about fertility issues. It's actually pretty good. So 60% of them were actually told that they can have infertility after cancer treatment. And 50% were actually informed about sperm banking. Also very good. But if you truly asked, do you want to have kids after you're cured? 51% of them said yes. And in fact, among those young males without kids, 3/4 of them said that they wanted to have kids after. However, what's dismal is the people that actually ended up banking was only 1/4. So 3/4 of them said that they wanted to have kids. Only 1/4 of them ended up sperm banking. And this is where I think we as urologists need to play a very important role in being the interface between the patients, between the sperm banking, between the oncologists, trying to figure out how we can increase this 27% number to 3/4 of those that are interested. The ASCO was fantastic, both in 2006 initially and then in 2018, made very good guidelines on fertility preservation. They basically said we as oncologists need to be discussing the risk of infertility at the earliest time, at the time of diagnosis, not at the time of treatment planning, not at the time of protocol planning, but really at the time of diagnosis, because that's the best time to do it. And truly, these patients should be referred to a fertility preservation specialist if the patient is interested. And I think this is what's very important. If the patient's not interested, I don't think we should worry about it. But if the patient is interested, we need to have a reproductive urologist and a reproductive endocrinologist to offer counseling. This is not the job of the oncologist. I think as reproductive urologists, we are very well trained in having these difficult conversations at these difficult times when the diagnosis has been given, with the parents, with the child, sometimes very difficult conversations that the parents have never had with their kids, but we are trained, and when we should be doing this, and they should be referred, and we should be available to do this. And I think all of that are all very critical points in this. So if you look at the 2006 ASCO recommendations when they first came out, unfortunately, a nice survey done out of Northwestern basically showed 50% of the time nobody actually uses it. So still a lot of work to be done in 2006. And basically, if you go back and survey the oncologists, why didn't you use the 2006 guidelines? They've got good ASCO guidelines. Why aren't you doing it? More than 90 to 100% of the oncologists basically said, yes, I want to do it. Attitudes, right? I really think it's important. They all want to do it. But then if you end up looking at how many of them actually do it, it's less than 50%. So they don't refer the patients out. They don't talk to patients about fertility preservation. They want to do it, but they don't do it. Why? This is where I think we need to intervene and sort of educate the oncologists and educate them and tell them about how important this is and make the process seamless. And that's where half the trouble is you want to figure out where those barriers are, where those roadblocks are, and try and help both the doctors and the patients. It's not just helping the patients, we got to be helping the doctors, trying to make this process seamless. Survey done in 2014, basically surveying both survivors and their parents, and asked about different themes on whether fertility preservation in people who fertility preservation was not offered. And the one theme that uniformly came out in that survey was regret. Nobody ever told us that there was an option. Nobody ever told us what to do about it, both among survivors and their parents. And this was unfortunately a uniform theme that was present in both survivors as well as their parents. Right? Nobody told us, and I wish we knew before. And this is similar to the two cases that we presented early on, where now there's no sperm. Right? Nobody ever told them that 14 years old when they were diagnosed with cancer to see what options they had at that time. Premal Patel was my fellow 2 years ago. He's now back in Manitoba. Did a very nice study, which we published in JAMA Open this year, where we went back and looked at granular data among all of the centers in the United States that report with ASCO. ASCO started this as a quality initiative, and we went back and looked at all of the data from all of the centers. So truly a ground representation of what's happening in the real world, both among community oncologists as well as academic oncology practices, to see what is happening. Results were actually pretty reassuring. We're pretty far, but definitely reassuring. If you look at the percentage of females that were counseled about fertility preservation, were close to 60%. So that's very good. Surprising, I would think men would be counseled a lot easier because fertility preservation in men is logistically easier and financially less expensive, but certainly about 35% of patients are being counseled among all men. And we truly looked at the reproductive age window, didn't have adolescent data, but certainly when we looked at 18 to 46, obviously with age, we see that the percentage of counseling being offered is going down. However, and the percentage that's not offered is as expected, right? So we should be counseling more in the younger population than in the older population. And in fact, between the ages of 18 to 30, we're actually doing pretty well with close to 60 to 75% of patients being canceled. And so reassuring, but truly we want to see these numbers much higher in this age group. And the one thing that we are doing is that we need to understand that advanced paternal age in the United States and worldwide is increasing. Older men are fathering children as they get older, but certainly we should not discount the fact they're not going to have children. And I think that's a question that we need to be asking all the time about whether it is in their plans or not, and not just assume that they're not going to have kids in the future, that they're not going to get married in the future. And so it's important to have that conversation. Obviously, you guys have a different healthcare system in Canada, but in the United States, so much of medical care depends upon insurance. And so 16 out of the 50 states actually have mandated fertility preservation coverage. So insurance companies are asked to cover for fertility preservation. So if we look at states that have coverage, fertility preservation was offered a lot more, as seen in these blue bars, compared to centers that didn't have fertility preservation coverage. So interesting data, obviously, to say that we should be lobbying from the United States, at least on a state level, to try and get this covered by insurances. And these are obviously the 16 states that are covered by that mandate fertility preservation. These are not all states that Donald Trump. You can see that Texas and West Virginia, he still won, but they still offer fertility coverage. So it's not red and white, sorry, blue. That could be white. I mean, we're still contesting it. So the rationale for sperm freezing, right? So why should we do this, right? Ejaculated sperm is safe. It's non-invasive. It's fairly easy to obtain, and so freezing that is good. Sperm that is frozen can actually is good for decades. Nice paper out of FNS, I think, a year ago, basically showed that sperm that was taken out 5, 10, 15 years after the initial freezing was still good, right? Very reassuring. Parents often think that the sperm continues to die with time. No, it dies at the time of freezing, but after that, the quality of the sperm, regardless of the number of years, still remains. And with assisted reproduction, paternity is very good. Close to 50 to 80% of them who use the samples that have been frozen still end up having children. And it's nice to know only close to 15% of the patients actually discard the samples. So 85% of them that ended up freezing end up actually using those samples. And I think it's important to understand that the sperm that's frozen is good and can be used. In particular, pediatrics and adolescents and young adults, it's a specific population. Dan Nassau is a fellow with me this year. He's going to go on to become a pediatric urology fellow next year. So it's a nice mesh for him to investigate this question more, wherein what are we doing in the ages between 12 to 18, right? Forget prepubertal, that's a different story. But even between 12 to 18, can the patient even ejaculate? And if they cannot ejaculate, or if they're uncomfortable doing it, what are some of the options that we have? And at 12 years, 13 years old, patients certainly not, but the family even hasn't thought about parenthood. And we have to think about what are some of the long-term costs are. If the kid is 12, are they going to have a family at age 30, 18 years of freezing costs? How much is that going to involve? Are they going to have money for assisted reproduction at age 30? And what are some of the ethical considerations? Is religion a barrier for discussing these things? I think when we look at kids younger and younger, there's a lot more issues than just straightforward obtaining a semen sample and freezing it. And I think we need to be cognizant of that and be aware of all of the sensitivities before having that discussion with that patient population. There's a nice study that we did with Josh Halpern from Northwestern last year to show that azoospermia risk at age 12 is actually pretty high. And this is not just among fertility preservation and cancer, but truly I think it's just a sign of puberty. So there's about a 66% chance that kids at age 12 will still be azoospermic. At age 13, there's about a 30% chance. And at age 14, 15, it sort of mirrors the adult population. So I think that's where it's important to understand that just because they are azoospermic at age 12, does not mean it's because of cancer. It could just basically mean because they are still peripubertal and not undergoing full mature spermatogenesis to have it in the ejaculate. When you do look at survivors with cancer, even pre-treatment, adults actually have a higher total motile sperm count than adolescents. Makes sense, right? You have more mature spermatogenesis, adults hopefully at Tanner stage 5, and so will have higher total motile sperm counts. But the important thing to understand is adolescents can still have spermatogenesis, and we shouldn't just discount it and say that they're not going to have enough sperm, and so we shouldn't be thinking about fertility preservation in that population between 12 to 18. So what do we do if there is no sperm and there is no ejaculate? Dr. Imad Ibrahim, our lab director, runs actually the spinal cord injury program. He's actually on this call, have lots of experience with penile vibratory stimulation and electroejaculation. And I think Dr. Flanagan came when he was a fellow at Cornell and actually took this course here. And we have a program in boys and in patients who are unable to obtain a semen sample with masturbation. So we're able to do yes and EEJ. And in rare cases, we just have to do surgical sperm retrieval, wherein both of those don't work, or if those are an option, we're able to do a testis biopsy to obtain sperm. So as reproductive urologists, we're very comfortable with all of these techniques to offer to the patients to be able to obtain sperm, because we understand that that window of obtaining sperm is so critical, and the time is not is of essence, and it's always on a clock before the patients need to start radiation, that we need to intervene quickly and do one of these things to be able to obtain sperm, because there is a chance that we may never be able to get it from them. Working with Dr. Schlegel, both I was a resident at Cornell and Ryan trained at Cornell as well. We're all very familiar now with the operation microdissection testicular sperm extraction, truly an advancement in the field, wherein now that patients don't have any sperm in the ejaculate, we're able to explore the testis and identify small areas of spermatogenesis, which we can use for assisted reproduction. So the two cases that I showed initially, that's the option that we have for them, is to explore the testis to find the small areas of spermatogenesis that we can use in assisted reproduction. If you look at post-chemotherapy, microdissection success rate is not that high. It's about 1/3. So 1/3 of the time we can actually find some sperm, and the sperm that we do find can result in a live birth rate of 40%. But it's important to understand that if they have been exposed to alkylating agents like cyclophosphamide, ifosfamide, cisplatin, the chance of finding sperm drops from 1/3, that's the average, to about 1/5. So very small numbers, but certainly it's better than zero, right? That's how I present it to the patients. It's right now the chance of having a child on their biological child on their own with their sperm is zero. And so with this operation, we offer them a 1/5 chance of even finding sperm. Again, a 1/10th chance of walking home with a baby. And as long as the couple understands, they understand all of the difficulty and magnitude of what is required with the sperm retrieval and IVF, and they're willing to go through with the process, it's okay. But this is not for everybody. It has to be a very detailed counseling conversation with the couple for this to happen and actually have an effect. A nice algorithm was published in 2014. Basically, if you're post-pubertal, peripubertal, or prepubertal, I think post-pubertal, I think you're familiar if masturbation is possible. Obviously, obtain sperm and freeze it. That's the easiest. If it's not, we discussed a little bit about PBS and EEJ, and then obviously to freeze there. If that's not, then we should be thinking about biopsy for testicular sperm extraction and then freeze that there. In prepubertal, this is experimental. We do have a protocol here at the University of developed by Dr. Imad Ibrahim to actually do a biopsy at the time.
So not affecting traction too much.
Whoever's on not on mute, please mute. So
Brian Mason, can you please mute your phone? Thanks.
So we can offer biopsy for testicular stem cell banking. So this is experimental, so we don't actually charge the patients. We just bill the procedure through insurance, but we are able to bank stem cells. I think in 20 to 30 years, when the kid actually grows up, there will be in vitro spermatogenesis technology. We don't have it right now, but we are able to do this. So in 8-year-olds, I think someone asked me a question earlier about what happens in prepubertal. So if the kid is undergoing a port placement or a bone marrow biopsy, we're able to do a testis biopsy and freeze the testicular stem cells for banking. These are all the options. Certainly something that we should all be very familiar with and discuss it with the patients and their families. So where does the future hold? Where are we right now? I think this is an area fraught for research and advances. And certainly thinking about testis biopsies and freezing them and transplanting them in the future is certainly a great idea. From the University of Pittsburgh, this was the first huge advance in fertility preservation. The paper was published in Science last year. This was basically a baby monkey that was born in 2018. And the way they did this was a very elegant experiment. Basically, they took neonatal monkeys. They basically chopped the testes, castrated the testes, and let the monkey grow. And then when at the time of puberty, they basically grafted this under the skin. So just basically put the testis tissue back that was frozen at pre-puberty and then grafted it under the skin around the time of puberty and gave the monkey hormones to basically stimulate spermatogenesis and testosterone production. And it was beautiful. They were able to see lots of spermatogenesis back when they retrieved those tubules from under the skin. So they either put it under the flank skin or in the actual scrotum under the skin between the dartos, and they were able to retrieve mature sperm. So probably the first biggest advance to show that you can take prepubertal testicular tissue and give it hormones back in the same animal and stimulate spermatogenesis. So nice. It's it's not in vitro spermatogenesis, but truly in vivo spermatogenesis, but stimulated with hormones. But they were able to retrieve that sperm and use it with ICSI, where you see the needle going into the egg, and they were able to perform and able to obtain that monkey that was born in 2018. So biggest advance. So this is why I think this is going to happen in humans. We're not very far from that. If we're able to do this in monkeys, we should be able to replicate this in humans. And this is truly just grafting and transplantation of prepubertal testicular tissue. And I think if we are able to do this successfully, then I think doing prepubertal testicular biopsies and freezing them with a special protocol. This is not the same protocol that is used for adult testicular tissue freezing. And we obtained the protocol from University of Pittsburgh with Kyle Orwig's group. They've obviously made this huge advance, and we're very happy that we have that established here at the University of Miami. So the program here, when I came here, we started this. We didn't have a formal oncofertility program. And the first thing I did was we basically said we needed access to care. Patients were being asked to go to IVF centers to freeze. And I said, this for such a large cancer center here, the Sylvester Comprehensive Cancer Center, we needed to have this program. So in the first year, we actually saw that it was 3.3% of patients were offered sperm banking. And in the first 6 months, we were able to see that number go up to 20%. We're very happy that we were able to establish within the urology department, started the clinic. We had control over the sperm banking, and Dr. Imad Ibrahim was instrumental in establishing that program when we got here, and we're very happy with the advances that he has made. So I think if you truly start a fertility preservation program, you're going to see a lot of oncology patients that are being referred. We're definitely going to see the percentage of oncologists that decide to offer fertility preservation, and certainly to see increases in parameters. You're going to see it across all cancer types. And I think this is where the future is with the prepubertal boys with in vitro spermatogenesis. I think we still have ways to go, but this is where I think we're headed to with the future, with both tissue grafting, like we saw with the monkeys, and also certainly germ cell transplantation in the future. So how do you start this? I think we have to assemble a team, right? This is not a one-man effort. We need to have a reproductive urologist, a reproductive endocrinologist for the female side. We need to have buy-in from hematologists and oncologists, right? They need to be willing to refer. I've probably given 4 or 5 talks over the last 5 years to hematologists, hematology oncology grand rounds, and every year I get 1 or 2 more people wanting to refer patients. So it's not like you give one talk and you can sit and relax and all the patients are going to flow in. That definitely doesn't happen. And you have to have an andrology lab and staff that are available to do this readily. Kajal is one of the other staff members that we hired on, has been instrumental in trying to be available all the time, because you get a call on Friday night from one of the oncologists. They say they're going to start chemotherapy on Monday morning. You need to have your lab ready to go to freeze that sample that the parents are going to bring on Monday morning. You can't say it has to be done on Tuesday, on Thursday. So almost being available on an on-demand basis is probably a critical portion of establishing a successful program. Certainly, the not so obvious is also very important. Pediatric oncologists, nurses, nurse practitioners, those who counsel on survivorship, establishing a cancer survivorship program in the cancer center, having them involved in and using fertility preservation as an important element and a piece of cancer survivorship, I think is also very important. And we as urologists need to be having and reaching out to them to see how we can assist in this process. And it has to be going back and forth, right? I mean, we have to have access to the reproductive tissue cryobank, the operating room, if we need to do a testis biopsy, and certainly this is not a single person effort. This has to be a whole team that is necessary. So I think in conclusion, it is very obvious that cancer survivors actually want to become biological parents, right? They want, when they go on, when they are not offered sperm banking, when they are not offered options for fertility preservation, the only thing that they and their parents have is regret. And I think we as urologists and having discussions with the oncologist should try to avoid that, despite the fact that there is possibility after their chemotherapy and after having azoospermia. But I showed you that the numbers were pretty dismal, right? 20% chance of finding sperm if you've gotten chemotherapy with alkylating agents, 10% chance of walking home with a baby if you've had chemotherapy, right? As opposed to using fertility preservation and having banked sperm. The chances now, if you have a young female and no female factor, are up to 50 to 60% of walking home with a child. And I think that's where that difference is important and needs to be stressed upon to the oncologists and the hematologists. And I think I've showed you very well that cancer will affect fertility. Chemotherapy, that there is no risk chemotherapy. And I think that is very important to understand, regardless of fertility-friendly regimens, that we are going to have issues with fertility later on. And it's certainly a challenge in the pediatric and the adolescent and young adult population, where both the parents and the kid are incapable of having a conversation about starting a family. But it is that reproductive window that you have to get sperm, to obtain it, to freeze it with ejaculation, with penile vibratory stimulation, with electroejaculation, with testicular biopsy, testicular stem cell banking now in the prepubertal population. All of that are options, and reproductive urologists are very familiar with those procedures. But I think it's very important to understand that if we miss that window, we're gone. And once the chemotherapy starts, especially with platinum and cyclophosphamide and ifosfamide, I think the DNA damage is almost immediate, and we do miss that window of sperm freezing, and that's why that time window is very critical. And I think sperm freezing should be considered even if the numbers are low, because assisted reproduction with ICSI and IVF requires 10 to 15 moving sperm. And so even if the numbers are small, we should definitely be thinking about it. And I think for all of those of you, I know Brian's established a very robust research program with a fellowship and so many young people listening. There's lots of opportunities in this fertility preservation space to move the field forward, despite the fact that we showed data that a lot of oncology providers are thinking about it and referring patients. There's still room to go and room to develop this, both in terms of improving access to care, mandating fertility preservation at the advocacy state level, and certainly lots of research on the science level to talk about in vitro sperm maturation and certainly testicular tissue grafting to see what factors are actually required to make human spermatogenesis. With that, I'd love to wish all of you best wishes from the Ramasamy team, and hopefully all of you can stay safe. None of this effort obviously would be possible without a huge team effort, and I think Ryan's doing a great job trying to establish something similar. But thank you all for having me. This is my contact info, but happy to take questions with the remaining time.